So I just have one housekeeping announcement first. As you know, my name is Jerry Feldman. I'm the moderator of this session, and I'm very pleased to be here and moderating this session. The session is being streamed live across the globe for the first time for the American College of Medical Genetics and Genomics. So if you are watching the live stream and have any questions, please click on the Q&A tab to send in a question or comment. Also, please make sure to remember to mute your electronic devices, and please refrain from taking photos of the slides that are HIPAA and copyright concerns related to that. So I'd like to begin my presidential address by talking about ACMG in the genomic era, how ACMG is working for you. And I thought a lot about this topic, and I thought that I could talk a lot about the future of genomics and the future of medicine and how they relate together, but I really thought that we've done that before, and so I'd like to make this talk a little more practical. Let's see if this works. And I'm the director of a molecular genetics diagnostic laboratory that performs clinical testing. That's my only conflict. So I was doing some reading about what makes a good speech while I was preparing for this talk, and I came across this. Speeches are like horns on a steer. There's a point here and a point there, but in between it's mostly bull. So my only question is, are they referring to this or this? And so my objectives today are really to take what I talked about last year, and remember last year I talked about the myths and realities facing us as a medical specialty, and I discussed the changes that I thought needed to happen for us to continue to succeed. And I occasionally hear from members that ACMG is not doing the things that are important to them, or why hasn't ACMG done something about situation X, or I pay a lot in membership dues and I don't feel like I'm getting money's worth. So today I want to focus on ACMG efforts to address the issues that were identified by the membership in the 2015 membership survey as most important. And there'll be a survey in 2017 as well, so I'm working on information that's a little bit old, but I think quite relevant. And I also want to discuss some opportunities to improve our practice models. And again, remember I talked about some of these things last year, and we were fortunate to have an ACMG Summer Scholar student, Teresa Kaminsky, who worked with me last summer to develop a survey to look at the changes that some programs or some clinics have instituted. And I'm going to discuss some of those preliminary results today from that survey. We're still collecting data, and so it's not complete, but I think I was able to glean some key points and some interesting things that I hadn't really thought of. So I use this slide to show you two things. One, the new banner for the ACMG in Action that the members actually voted on, and this was the one that was selected. So you're seeing this, I think, for the first time. But of relevance to this talk, I also wanted to talk about the top two categories of articles that members clicked on in ACMG in Action, and these are ACMG guidelines and statements and advocacy and reimbursement. And so I'm going to talk about those issues as well. Now here were the four top priorities that were identified in the 2015 membership survey. Reimbursement for genetic services, increasing the medical genetics workforce, oversight of genetic testing, and genetics and genomics education for non-geneticists. So I'm going to speak to each of those as we move forward. But before I get into these, I want to talk about a few current issues that were not on the minds of members in 2015. The first is our meeting next year, which is going to be in Charlotte, North Carolina. And as you know, North Carolina House Bill 2, also known as the bathroom bill, is in effect in North Carolina. And we've had some comments from members who've requested that ACMG move that meeting to a different location. Let me first say that ACMG is committed to creating an inclusive and welcoming environment for our members and attendees and opposes discrimination of any kind, including HB2. Also keep in mind that many states have laws that many of us would not support. And in fact, for those who aren't aware, there are 13 other states with similar bills as HB2 in the pipeline. So it's really impossible to predict ahead of time what might happen in a particular state. It's financially, realistically prohibitive to cancel or move a meeting. Our contract was signed many years in advance prior to HB2. It would cost ACMG millions of dollars in lost revenue, and in fact there would be no meeting in 2018 because it's too late to try to identify a site for a meeting this large. So the Board of Directors has considered this carefully and made the decision that the meeting will remain in Charlotte. We're working with the Charlotte Convention Bureau to make sure that all individuals have proper availability of a bathroom of their choice, and Charlotte is committed to that. And so I would urge all of you to continue to support ACMG's mission, which is to develop and sustain genetic and genomic initiatives in clinical and laboratory practice, education and advocacy, and please plan to attend the ACMG meeting in Charlotte. Second, we all know that there have been lots of changes with the new leadership at the federal level, and one of the things that has been brought by many members to our attention is, does ACMG have a policy on the immigration issue? And so again, I want to make sure that you all know, although this has been sent out to you in other ways, that ACMG supported a statement by 36 other organizations that was put together by CMSS, and I highlighted the fact that it was really related to what we saw as an impact on patient care, medical research, the education of health professionals, and international scientific collaboration, and we call on the national leaders to eliminate these barriers to scientific exchange in medical education. Thank you. I also want to comment on a fast-moving target that we were just involved in the last week or so, and this is House Resolution 1313. Most of you just know it as 1313, and this is called the Preserving Employee Wellness Programs Act. And what this says is that employers would be allowed to collect genetic information about employees and family members who are enrolled in wellness programs. Employers would be allowed to request genetic test information. Employers could charge penalties, which could be in the thousands of dollars if an employee refuses. And as you know, currently there are laws on record that prevent this. Both GINA and ADA prohibit this, and ACMG is on record as supporting both of those. And so ACMG joined 65 other organizations and sent a letter opposing this bill on March 7th to the House Committee Education and Workforce Committee prior to the vote from that committee, of course, but the bill passed out of committee by a party line on March 8th. So I would urge all of you to contact your congressmen and your representatives if you oppose this bill, and make sure that your opinions are known. Another thing that was not known, or really not on top of people's minds a couple of years ago, was genome editing. We know that that's also a fast-moving target. ACMG does have a policy on that, and I just highlighted the very important components of that, and that the current limitations of these technologies must be overcome prior to any clinical application. That application in the clinical world must have stringent medical and genetic review, and that genomic editing in the embryo is certainly premature and should be subject to vigorous ethical debate and further refinement. That was a statement today that the Board of Directors approved and has been out there for a couple of months. For those that are interested or have some sense of involvement, I'll let you know that an ad hoc committee has been formed to recommend specific areas where ACMG can contribute to this discussion, and Dr. Bruce Korf will be chairing that ad hoc committee. We're still working out the logistics and the committee makeup, but certainly if you're interested or have some expertise, feel free to contact Dr. Korf. Okay, let's get back to the member survey and look at the top 4 priorities again, and let's go through those one by one. So what has ACMG done in regards to reimbursement for genetic services? And I'll go through a couple of different things that hopefully you've seen along the way. These are not new things that haven't been publicized as well, but I know that some things sometimes slip through. But in late 2015, as a result of a change in Medicare's national coverage decision policy, many cytogenetic tests that were previously covered were no longer covered. And that had to do with the conversion of ICD-9 to ICD-10 codes. Well, our Economic Committee, which is a standing committee of ACMG, took it upon themselves to develop an extensive list of ICD-9 codes, converting them over to ICD-10 codes. A letter was submitted to Medicare requesting correction of this discrepancy, and in 2016, Medicare included an updated list of ICD-10 codes and included many of those that would be covered for cytogenetic testing. It didn't include all of them. We're still working to try to make that process continue to improve. But many labs were able to report back to ACMG that they received payment, including back payment, for previously rejected claims. So I want to thank the Economics Committee for taking that task on, and I feel like that's been a benefit to many labs. As clinical geneticists, we all know about RVUs. We may not like them, but they're here. And so the college has also been involved in trying to determine and help with the process of determining whether the RVUs that have been identified for clinical geneticists are really accurate and come from geneticists themselves. The University Healthcare Consortium Family Practice Solutions Center has now greater than 250 clinical geneticists who have enrolled in their RVU benchmarking process, so the geneticists are now reporting their own RVUs instead of some other organization determining what that should be. Now, there's a little bit of a trick to this. If you're at institutions that participate in the UHC, you can obtain this data, which is objective and externally validated. And in fact, the new data showed a little bit lower benchmark than what had previously been identified for clinical geneticists. As I said, there's a little bit of a hitch to this. They will release their data only to members of this consortium. So you need to check with your local institution to see if you can obtain that data. And if you have additional questions on this, talk to Dr. David Flannery, who is the ACMG Medical Director. One thing that had gone unnoticed for many years was that there wasn't a taxonomy code for clinical genetics in CMS. And how that happened is really unknown to me, but I'll give you what I think probably happened. But essentially, once that was identified, it was actually identified by one of my former trainees who was trying to become credentialed at her institution, and she was board certified in only medical genetics or in clinical genetics, and so had to use a different code that was sort of for anybody else who didn't fall into some other code. ACMG took it upon themselves again to submit a letter to CMS to request a distinct specialty designation code for clinical genetics and genomics. That will allow CMS to assess physician practice patterns and quality of care provided to Medicare patients, and allows clinical geneticists to be able to be eligible to enroll in Medicare program as physicians with the specialty of clinical genetics. It will be important as we move forward with these various incentive-based payment plans that are based upon quality improvement and outcomes. Why hasn't that happened in the past, and who really knew that this hadn't happened? I think nobody knew because, first of all, most board most clinical geneticists historically were board certified as in another specialty, so you were credentialed in pediatrics or OB or internal medicine, so it really never came up that genetics hadn't been established as a separate code. And then until recently, as we've become more involved in the adult population, many geneticists just didn't bill Medicare, so it never became an issue. The decision on this is pending. We're told that the last specialty who went through this process, it took 12 months for that to be completed. We submitted this last November, and so we're still waiting, and it's unclear with the new federal government whether that process will be increased or not. We just don't know. So that decision is pending, but I think it's important to keep an eye on that. We also know how important CPT codes are as it relates to reimbursement. And Dr. Flannery, again, our medical director, has been invited to attend the AMA CPT molecular coding meeting that defines the framework for genomic sequencing panel-based tests. And in addition, ACMG recently joined a coalition formed by AMA and AHA to advocate on relieving the burden of prior authorization. As you know, we all hear a lot about the time spent by our staff on prior authorization. And this coalition is going to work to lobby healthcare plans to streamline the prior authorization process for medical tests, procedures, devices, and drugs. So a very important part of what we do. The scope of practice document was revised and updated a couple of years ago in 2015-16. And I bring this up because I think it clearly delineated the role of the medical geneticist, and it distinguished very clearly the difference between a medical geneticist and other genetic healthcare professionals, and included in what a medical geneticist does were genetic consultation, genetic counseling, treatment of genetic disease, including clinical trials, and I won't read the rest of it, but you can see it's a comprehensive evaluation of a patient. It's useful for hospital delineation of privileges. If you want to receive privileges as a medical geneticist, it's an important way to outline what exactly you do, also important for insurance companies. And then the ACMG salary survey, which I'm sure most of you are familiar with. It's the only survey to specifically collect compensation data for our specialty. There'll be the new survey just came out. Many of you have used this salary survey as a way of negotiating your individual salaries. And I would say that ACMG would be interested in knowing more about your experience with your administrators and how successful using the salary survey is. I know at our institution it's been very successful. So, to summarize, I think it's important for you to realize that ACMG is involved in these issues. We recognize them, and we're trying to do something about that. These are big ticket items to try to solve. Increasing the medical genetics workforce. How have we done in that? And I think you can see from my tone, probably not great. We have done some things, and you saw the awardees here. A number of new trainees received fellowships from Shire Pharmaceuticals for training for medical geneticists, for medical biochemical geneticists, and the specific purpose was to help address the shortage of medical geneticists. And the idea is to award these to institutions that don't currently have adequate funding to support these, though they might have an accredited training program, so that we want to make sure that we're increasing the number, not just funding institutions who already will be training individuals and have funding. And so we gave out a number of awards this year, and I think that's the beginning of a process that will hopefully be successful over the next number of years. There's a new fellowship in genomic medicine program management that ACMG and NICHD are partners in. And this is a fellowship to lead genomic medicine research and implementation programs at the NIH. The individual will spend time in the ACMG office as well, developing projects for ACMG. And this is open to physicians with a strong interest in establishing and managing genomic medicine programs. The idea is that this will help to increase increase that number of individuals in that specialty as well. And finally, ACMG supported the new laboratory specialty in laboratory genetics and genomics. But I think, sadly, we really have not done the best that we could do in increasing our workforce. And I took a look at the match data from this week, or last week, I guess by now, and the numbers were sort of level in terms of how many individuals matched into the combined pediatrics medical genetics residency and the internal medicine medical genetics residency. In the categorical residency match from last November, we were also level. So I think that we need to do more, and I have some ideas I'll talk about later in this talk. Let's talk about oversight of genetic testing. ACMG, as many of you know, especially on the laboratory side, was actively involved regarding possible regulatory actions that the FDA was involved in related to laboratory developed tests. We were there in terms of briefings to Congress that we urged them to modernize their framework for high complexity tests by reform of CLIA, not by oversight of the FDA. We wrote a letter to the FDA. Dr. Flannery testified at an FDA public hearing outlining ACMG's position. It's a little bit evolving as I speak. FDA withdrew the release of their lab test guidance last November, primarily based upon the uncertainty of what was going to happen post-election. Yesterday, though, we became aware of a resurrection of this FDA regulation process, and it's really a similar version of previous drafts making its way through some of the congressional offices. And so there'll be more to follow on that, but to make sure that you know ACMG is aware of this and is on top of it. We've had a couple of policy statements related to oversight, recommendations for reporting of secondary findings in clinical exome and genome sequencing. We updated the original list of minimum genes. We eliminated one gene, added 4 genes. That was published last year. And we revised our direct-to-consumer policy statement in 2015 as well. And among those recommendations was a minimum requirement that a genetics expert, such as a certified medical geneticist or genetic counselor, be available for discussing results of patients who go through the process of direct-to-consumer testing. We've published a number of practice guidelines over the years as I've been president, and I just listed a few. I won't go over those. There are many more that have been published beyond those, but I point out the fact that there are both standards and guidelines that relate to laboratory testing, that relate to clinical delineation of syndromes, and relate to the interpretation of those variants as well. There's a new non-invasive prenatal screening statement also released at the end of 2016. As we look at genetics and genomics education for non-geneticists, what kinds of efforts have we had there? We have a policy statement regarding clinical utility of genetic and genomic services that basically states that there is utility that insurance companies may not understand as it relates to utility. We talk about these things all the time among ourselves. There's now a policy that states that it should take into account effects on diagnostic or therapeutic management, implications for prognosis and health, and psychologic benefits to not only the patients but to their relatives, as well as looking at the economic effect of healthcare systems. We've developed some practice guidelines for non-geneticists. We have referral indications that we did in combination with the NSGC for cancer predisposition assessment. We took the PKU guidelines that were published a couple of years ago and translated them into six different languages as well. So different things that will be helpful for some who practice some genetics who are not really board certified geneticists. I talked a little bit about advocacy at the beginning on some really topical things, but here's a few others that are not only historically topical, but are now becoming very more topical in the recent months. We proposed an AMA resolution to support legislation mandating insurance coverage for medical food products that are used to treat inborn errors of metabolism. And this is important because once the AMA passes a resolution, they're able to use all of their efforts to lobby for this type of coverage at the federal level. There are some efforts that relate to that in the sense that we have been involved with some congressional legislatures who are interested in supporting this bill or a bill similar to that and moving it forward. And that's been very recent. We have a policy statement on laboratory and clinical genomic data sharing. That's important as it relates to the health of our patients so that we can ensure that our patients receive the most informed care possible. That's a policy statement that just came out last year as well. And for those of you who ask the questions all the time is what is ACMG doing about what's happening with health care and the NIH budget, we're aware, we're working on it. We understand that there's a big picture involved as well, and there are many other organizations that are actively involved as is ACMG, though there hasn't been a public statement or a policy statement on those topics yet. So here's the results of the survey, or some preliminary results of the survey that I talked about at the beginning, and I summarize them by increasing efficiency and decreasing wait time in medical genetics clinics. Some of these may be quite familiar to you and things that you've already implemented. Some may be just logical to you. Many clinics have taken on hiring non-MD and non-staff, non-genetic counselor staff. We all know of the shortage that some clinics are experiencing in relation to genetic counselors. By hiring genetic assistants or nurses, we've done that at our institution. We have 2 genetic assistants who are quite helpful in what they do. And that really involves triaging patients for booking, obtaining medical records, doing pre-auths, those kinds of things. And it's quite clear that there's a separate job description for those individuals from a genetic counselor, and we make certain that we're not overlapping those. Some have implemented ordering routine genetic tests prior to the genetics appointment so that when that patient comes to the genetics clinic, those test results are available at that first appointment. And so they'll work with the primary care doctor, determine that we're going to order a microarray or something like that when the patient comes to clinic anyway. We can tell from the medical records. So I think that's a helpful idea. Decreases some of the paperwork for your own clinic, as well as having those results available. And many of us do this already. Normal test results reported by phone or some type of EMR message in those systems that now have that available with mail copies to follow. To decrease no-shows, they've instituted appointment reminders, phones, texts, maintaining a wait list of patients to fill cancellations at the last moment. Again, I would say these are not things that are rocket science, but things that a clinic could probably do a better job of putting together a system. This was interesting. A few clinics have eliminated their annual evaluations for patients with a known diagnosis such as Marfan syndrome. And what that does is frees up time to see new patients, so frees up clinic slots to see new patients. And so I thought that was interesting. That was something that I hadn't really thought about. And again, I want to thank our ACMG Summer Scholar student, Teresa Kaminsky, and my program manager of our residency committee, of our residency program, who also worked with Teresa, Michelle Saikon. Many of you know her. So is there still work to be done? And I would say absolutely. I don't have an answer for some of the questions that we've asked, but I would ask whether you think ACMG is doing the best that we can, and I would also ask if you think that you're doing the best that you can to encourage medical students to consider a career in medical genetics. I think it takes each one of us individually to make that happen. So what have you done within your own institution to increase the recognition of genetics as a separate medical specialty? I know that our medical students get that information during the first year, but they really don't remember it as their third and fourth years come about, and they lose their focus and interest in genetics over that time. So we're working, for example, on developing a 4-year curriculum of genetics, and I know some other schools have done the same. We need to follow up a little bit better with the ACMG Summer Scholars throughout their medical school career to make sure we understand their reason for wanting to be an ACMG Summer Scholar and whether that resulted in them entering a career in medical genetics. And individually, I know of those that have entered medical genetics, but we've also had experience with a number of others who have not. Has ACMG done enough? I'll leave that up to you to answer. I would certainly be interested in anybody who has ideas of other things that ACMG could be doing or can be doing to help with this process. And one thing I think we need to do a better job of is collaborating with other organizations such as ASHG, the Professors Group, Association for Molecular Pathology, and NSGC to continue to move forward our priorities, which are part of our strategic plan, because we can't do this alone. So what have I learned as president for the last 2 years? Well, a philosophy professor once asked a student in your class, if you had 1 year to live, what would you do? And the student replied, I would stay in your class because 1 year in your class is like an eternity. So having finished 2 years as ACMG president, I think I've experienced that times 2. But I'm honored to have served as your president in this position, and I want to take a couple of minutes to thank those who've served me so much during my career in medical genetics and provided some amazing mentorship that has served me well in the last couple of years as president. First, I'd like to thank David Weaver, who was my first true mentor at Indiana University and convinced me to stay the course and work towards what I wanted to be in the end. And then at the Medical College of Virginia, I want to thank both the chair of that department, Walter Nance, and my PhD mentor, Barry Wolf, who continue to provide me with advice on things related to future opportunities. And then I'd like to thank my fellowship mentor, Art Baudet, whose lab I trained in and learned the ins and outs of both molecular and biochemical genetics as well. So thanks to all of them. Thanks. And as Diana said, I certainly couldn't do this without my family. So I'd like to thank my 2 sons, Mark and Jake, and my wife, Git, who taught me that while you can take the Feldmans and put them into the most beautiful baseball park in America, which is Fenway Park, you can't take Detroit out of the Feldmans. And so I'll end with this slide. I used this slide last year, and we talked about whether the glass is half full or half empty. Well, I'll remind you what Mark Cuban said. It doesn't matter if the glass is half empty or half full. All that matters is that you are the one pouring the water. So thank you for allowing me to be the one pouring the water for the last 2 years. Thank you.